She will be joined soon. So meanwhile, we're discussing about pressure sources and wounds also. So mostly we can see so many wound managements in palliative care because in palliative care most of the cancer patients we are seeing day to day practices. So we can see malignant types of wounds is there. So we can say malignant wounds and pressure source we can see in every day for patients. So there are different types of managements for malignant wounds and pressure source. So mainly today, I think the subject is focusing regarding pressure source. So have you ever known can anyone see the pressure sources or malignant wounds in your day-to-day basis? I think you are the students, nursing students, right? So can anyone know about the pressure source and malignant wound? Have you ever seen in your practices?
Hello, good afternoon, ma'am.
You can unmute your mic and you can say.
Good afternoon, ma'am. Ma'am, I have seen only pressure sores, no malignant sores. I've never seen.
So, Mr. Sohail, can anything say regarding pressure sources or malignant wounds?
Good afternoon, ma'am. Ma'am, I have never seen malignant tumors. Malignant bed sores never seen, ma'am. But simple bed sores I have seen them, and only simple bed sores, not malignant bed sores, never.
Okay. So, what are the precautions for pressure sources?
We can just change the
Practice.
patient's position within 2 hours and clean the
Yes.
wound, keep the wound dry.
Yeah.
That's it, ma'am. Most importantly, we have to change the position of the patient every 2 hours.
Okay. What are you are practicing for to prevent the pressure source regarding if patient having pressure source? So, what is your management for that?
Just to keep the wound clean and change the patient's position every 2 hours, ma'am.
Okay. Which medicine you are using for pressure sources? Like topical agents.
We can use for pressure source. No, ma'am, I don't know, ma'am.
Here we are using metronidazole powder
Okay, ma'am.
tablets. So it will act as an anaerobic agent. So it will reduce the smell.
Okay, ma'am. Thank you.
Thank you so much. And Anshu, can you say something about malignant wounds or pressure sources? Miss Anshu.
Good afternoon, ma'am.
Good afternoon.
Ma'am, I've seen only pressure sores. Prolonged
Okay.
sitting और lying position में अगर patient रहता है तो स्किन पे जैसे एक ही जगह पे प्रेशर डालने की वजह से वहां पे सोर्स हो जाते
Yes.
हैं. हाँ जी मैम.
Okay.
काफी डीप था मैम उनका. मैं जो पहले
Ah,
मेरे एक पेशेंट था उनको देख रहे थे.
okay. Okay. Thank you. Thank
तो मैम उनकी ड्रेसिंग किया करते थे हम. और टी बैक्ट मैम ऑइंटमेंट हमने टी बैक्ट मंगवाया हुआ था. म्यूपेरोसिन टी बैक्ट. तो उसके साथ हम ड्रेसिंग किया करते थे.
Okay. Okay. Thank you so much. I think Revati ma'am joined. I think ma'am is here. Here.
Good morning.
Good morning.
Can I
Welcome. Welcome for this session, ma'am.
Thank you.
You can continue, ma'am.
Okay.
Before you join, only your introduction finished. Sorry for that.
That's okay.
Thank you.
Hi all, I'm Revati Saravanan. I'm MSc nursing candidate. Then I have completed my CCPN course in Palliative, India before 3 years. Now I'm actively working as a nursing assistant professor as well as a palliative care trainer in SNS College of Nursing and KMCH hospitals in Coimbatore. Then I have. So thank you. This is my introduction. You can see that.
Yes.
Then I am a patent designer as well as we have rights on 3 patents for helping for bedroom patients as well as the spinal cord injury patients. So this is my small introduction. I have completed my UG and PG in MGR University. So this is my small introduction. Before 3 years, we have attended in direct class in Pallium India. Such a wonderful experience in Pallium India. We had that. So thanks to Pallium India and Sparsh Hospice for this opportunity again. Then thanks to Echo team. Now can we go to the topic?
Yes, ma'am.
Okay. Can you see my screen?
No, ma'am.
Just wait.
Revati, ma'am.
Arya, can I send to you? Can you share for me, please? Arya, can I send to
Revati, ma'am,
you?
are you facing any technical issues?
Yeah, yes, somewhat issues I
You're
am
on
facing.
mute, ma'am.
Can you hear me?
Yeah,
Can you hear me?
Yeah. Yes, ma'am.
Can I share my PPT to you? Can you display that?
Yeah, yes, ma'am. Sure.
I'll share now.
So, dear participants, you can share your experience. Meanwhile, you can put it in chat box regarding pressure sources and bed sources. And if you have seen, you can mention malignant wounds also. Sorry, some technical issue is going on. So we'll discuss regarding malignant wounds. So malignant wound haven't seen, but there are some carcinous cells which destroy skin tissue causing malignant wound. Yes. So is it curable? Malignant wounds are the curable one? You can unmute your mic and you can say, is it curable or not? What is the goal of care for malignant wound?
Actually, I haven't seen the malignant wound, but I have read it somewhere. So I don't know the specific management about that, but I've read it somewhere. From the malignant, it means it's something cancerous. So it
Yes.
can, that is the thing. I don't know the proper
It
answer.
cannot curable.
Okay.
So the malignant wounds are not curable. So our goal is to prevent infections and maintain hygiene. So for pressure source, we have to change the positions and give skin care. So the bed source we can preventable and we can take precautions for that to prevent the pressure source. We have to change every second hourly positions and maintain skin care properly. Okay, now we can see what it will be. What are all the wounds we can see in palliative care. Thank you.
Sorry for the inconvenience. Some technical issues here we are facing for 2 days. Sorry for that. Okay. Now we are entering to the topic wound management, that is pressure sore management. Okay. Arya, can you go to the second slide? Next. So all of you aware of pressure ulcer now? I hope so. So pressure here, you can see the definition. Pressure ulcer is localized injury to the skin and other underlying tissue, usually over a body prominence as a result of prolonged unrelieved pressure. Here, you have to understand pressure ulcer is starting as a localized injury on the superficial skin in initial stage. Okay, and then it will go to the other underlying tissue under the skin, usually over a body prominence as a result of prolonged unrelieved pressure. In third line, you have to note that as a result of prolonged unrelieved pressure. Here, we can understand that unrelieved pressure on the skin on the patient is delivering a damaged tissue that will lead to the localized injury to the patient. Okay, so this is the real definition of pressure ulcer. Some of you mentioned some blisters, local skin damage, injury, first skin redness. Yes, this is the symptoms. We are going to see that in deep involvement. So next slide, please. So here you can see the pathophysiology of pressure ulcer. So what pathophysiology means, how the disease occurs in the, how any diseases, any type of diseases, any type of injuries, any type of wound, how is entering into our patho in body and how it is turned into a uncomfortable disease to our body. That is called pathophysiology. The physiology means you can understand the setup of damages. You can anatomy of wound, like that you can understand the pathophysiology. First one here, pressure for a long time. So pressure for a long time means one part of the body continuously, it is getting pressure for a long time. Okay, without any disturbances, it is only getting pressure. Then, so that is leads to collapse of blood vessels. Our skin and our body is full of many blood vessels are there. So that blood vessels getting collapsed. Okay. Then that is leads to perfusion of tissues. Okay. Tissue perfusion will occur. So nutrition, oxygen, and other sources of skin and blood vessels will be disrupted due to the collapse of blood vessels and pressures. Then that is leads to the tissue ischemia. What is the meaning of ischemia? Anyone know? Put it in comment box.
Lack of oxygen.
Loss of blood supply.
Loss of blood supply, loss of oxygen. Then yes, you people are right. Then loss of blood supply to the particular tissue is called a tissue ischemia. Then hypoxia, decreased oxygen level to the cells. It will lead to the cell death because how our cells are getting life through nutrition, oxygen, and many nutrients we are taking through food and through the environment, like vitamin D we are getting from sunrise, no? So like that, our cells also getting nutrition, oxygen through our metabolism. So that will affect. So tissue ischemia and hypoxia will lead to the cell death on the particular area. So it will cause the cell stress to the particular area. So it will cause the breakdown of the skin on the particular pressure area. Why I am mentioning particular area? Particular area means in coming slides, you are going to see that which areas are prominent to getting pressure ulcers. That is, I am mentioning here particular areas. So this is the pathophysiology of pressure ulcer. You have to understand how it is happening. Pressure ulcer. Then only you can give the proper care to the patient. Then only you can understand how we are going to treat, how our treatment is going to treat the patient. Okay. See, in this image, you can see the skin layer. Okay. So in second picture, you can see the skin layer, that is body weight, bone, muscle, tissue, skin. Here in a down area, we can see the mattress, you know. Okay, mattress is giving friction to the skin, that will give pressure to the tissue. That pressure is continuous pressure is there, then it will affect the muscle too. Then bone will till bone it will cause the damage. Okay. Upside we can see the body weight, because body weight also giving pressure on the upside. Our mattresses also giving pressure through the skin. So in between area will get friction. So contradiction happening is there. Okay. Then next slide. Next slide, please. So here you are going to see the risk factors of pressure ulcers. We are saying pressure ulcer. What is the cause? Every bedridden patient is prone to get pressure ulcer. What is the risk factor? We have to know first. We have to address that first. First one is friction. Before the slide, this slide, I have shown one picture. No, between the mattress and between the body weight, we are getting friction through the skin area. That is, in Tamil we are saying oraivu, that is friction. Okay, so that friction is lead to the shear. Shear means we are not giving a proper bed sheets to the patients. We should give the clean and neat, wrinkle-free bed sheet to the patient. But some of them, some of the movements and some of the lacking of care, they lead to the shear position. So it will cause the pressure ulcer to the patient. Then impaired sensory perception. See, we have seen many patients like stroke patients, then cancer patients, then prolonged bedridden patients, geriatric patients. We have seen lots of patients. So their sensory perception getting decreased due to the pathophysiological conditions of the disease. So their sensory patterns will be disturbed. If in a normal people, if for a healthy adult, we can know something is disturbing our skin. Suddenly, what we will do? Suddenly change the position. Suddenly change the sheet. Suddenly we will change everything. But in the particular bedridden cases, in the geriatric cases, they don't understand what is disturbing them, because decreased sensory perception. Then impaired physical mobility due to the lack of activity, due to the condition, disease condition, they are not giving much physical activities like a healthy adult. So that is impaired physical mobility also will cause a pressure ulcer. Then altered level of consciousness. Before I'm telling, there are some geriatric patients, some neuropathy patients will have altered level of consciousness. Okay, they don't know. Initially, we are doing consciously everything. We have to put this dress, we have to put this bed sheet. Oh, the bed sheet is so wet, we have to change that. Like we are planning, but they don't know. So altered level of consciousness also plays a major role here. Then fecal and urinary incontinence. This is the lack of care department. Why I'm telling like that means fecal and urinary incontinence will cause a wet to the patient bed and patient dress also. So that caring person who is going to give a care, that person should change the wet cloths and wet bed sheets often. But they are missing. There is a lack of hair happening. So the patients are going into the wet bed for long time. So that wet is making pressures to the skin. Okay, that is the major role in pressure ulcer. Then malnutrition, then dehydration, lack of water intake, then excessive body heat. Then excessive body heat also, because there is no air circulation in the area, then there is no proper sanitation in that area, will cause the heat to the particular room, particular bed. So that will also make them to make their body into the excessive heat. So blisters will arising. So advanced age. So geriatric people commonly they are affecting with the dehydration, then metabolism disorders, then fecal and urinary incontinence. So that is also a main reason for the pressure ulcer. Can you able to understand me?
Yes, ma'am.
Thank you. Next slide, please. Here you can see the common sites of pressure ulcer. In first definition itself, I have told you some particular prominence areas are getting often of pressure ulcers. Here you can see that in second picture, the acciput area, scapula area in backside, and elbow area, sacrum area, ischium area, and heel area. These are the common sites of pressure ulcer. We are mostly, some people, unaware people are thinking only bedridden people is getting pressure ulcer. That is a wrong thing. Wheelchair patients are also getting pressure ulcer. Less activity people also having pressure ulcer. So you can see in first picture, you can see the common sites of pressure ulcers, how it is affecting the persons. First, you can see the locations in lying position, back of the head, shoulder blade, lower back, and elbow, then heel. Those are the common sites of pressure ulcer. In side lateral position, you can see the again shoulder, elbow, hip, and between the knee and ankles. These are happening with skin friction. So due to the skin frictions, there is a result of pressure ulcer in between the knees and ankles. Then here, prone position and Fowler's position. You can see back of head, shoulder blade, lower back, sacrum, heel. Then wheelchair patient. See, clearly we have mentioned here, shoulder blade also affecting, lower back also affecting, hip also affecting, then sacrum area also affecting, then underside of the back and heel. That is also affecting in the pressure ulcer. Pressure ulcer is commonly for lack of physical mobility people. I have one experience. I have worked in yearly after my UG. I have worked in a IT company. I have to sit for a long time. So there is a full of AC, very cooling place, comfortable sheet. We can. I'll move some in between breaks, but that time also I have developed with pressure ulcer. So long time sitting, prolonged time in bed, and prolonged time in arch, then wheelchair will cause the pressure ulcer. Impaired physical mobility is the main reason for pressure ulcer. So we have to ensure that if patient is not able to do by themselves means, sorry. So if patient is not able to do by themselves means, caretaker or nurse have to change the positions in every suitable times in every intervals, recommended intervals. Okay, then we move to the next slide. Next slide, please. So you can see the real pressure sore images in different sites on the heel, back of the occiput. We will think how this will come behind the head. So you can see in the second picture, occiput picture. Then third, in the small toe. Then sacral area. Okay, this is a different type of wounds, pressure sores in different sites. We will classify that in next slide. Next slide, please. Common sites. So, before we see in that pictures, no, head, shoulder, elbow, buttock, heel, toes. You as a nurse, as an educator, you have to teach the caretaker. They have to check often these places commonly every day. And as a nurse, you have to give massages, you have to change the position, and you have to check these sites in every day as you are nursing care. Next slide, please. Next slide, please. Next slide. So you can see the prone position here. Chin area also will get affected. Head in the prone position, elbow area, chest area, reproductive organ, knee, toes, toenails also will get affected through the pressure ulcers. So these are the common sites in prone positions. Next slide. So here we are going to see the stages of wound. Next slide, please. Stage 1. Here you can see like little scratch wounds. Like this is the stage 1 wound of pressure ulcer. Okay, so can anyone explain the skin layers of human body? Or put it in chat box. Skin layers, dermis, epidermis, subcutaneous, we have no? Can anyone say?
Ma'am, it is first epidermis, dermis, subcutaneous, muscular layer, ma'am.
Okay, good. So epidermis, dermis, subcutaneous, and muscular layers. So like that only, we are getting pressure ulcers by stages. It's a superficial skin wound. In stage 1, we are getting like that. Then next picture, please. Next. So red, ma'am, stage 1. Red differently colored spot that do not blanch with pressure. Non-blanchable erythema. It is otherwise called non-blanchable erythema. We are leaving just like that. It is just a patient will say to us, I'm scratching, mosquito bite will happen, some ant will bite me. So so I got some itching, so I given some scratches, so I got this erythema, like that they will say. What we will think, okay, maybe it has happened, like that we will move on. But for a prolonged time bed patient, then impaired physical mobility is patient is having impaired physical mobility, means we have to notice that it is not just mosquito bite or scratching or itching wound. It is a stage 1 non-blanchable erythema. We have to understand that first. Then sometimes patients will bother to show the private parts to us. So initial stage, you have to gather a confidence towards you. Then you have to tell the importance of the conditions. Then you have to gain the confidence from the patient. Then you have to check first. Then you have to diagnose that, and then you have to start the treatment next. Second, stage 2. Here, you can see shallow open ulcer into the dermis. First picture, epidermis and superficial skin will got affected. In this picture, you can see some deep wound here, shallow open ulcers into the dermis. So we can, the little blood, tiny blood vessels eruption is happening here, and blisters will happen in the stage 2. So you can clearly see the pictures. Some one home in one home care in Coimbatore, we have seen patient is having many blisters in knee heel area. So we asked them how it is happening, like that. We asked, just they told, I pour some hot water, so it is the blisters came, like that she told. But in real incident, in real condition, she don't have access to take hot water. The caretaker is full and full giving water and everything to the patient, but patient is telling some hot water will poured on my knee, so it is happening like that. So patient will tell different type of suggestions, because they don't know what is exactly happening to them, what they are going through. So that in many geriatric patients, they won't accept, you have to move, you have to do something, you have to do this. Then we will, if we tell like that, means they will tell the advice to us. So in that conditions, you have to aware, this is not just blisters, it is a stage 2 shallow open ulcer or blisters by pressure sore. Okay, here you have to understand, you have to differentiate the blisters, hot water, hot blisters, or pressure ulcer. You have to know the difference in between them. Okay, then next slide, please. So stage 1, stage 2 will lead to the stage 3 ulcer, that is full thickness ulcer. So that is full thickness ulcer. Dermis area, epidermis area, subcutaneous area will be getting affected with the full thickness ulcer. So in this picture, you can clearly see the wound shape. Then there is no shape at all. That deep level affected areas. Then this stage 3 will lead to the channeling. That is a narrow opening or passageway that can extend it in any directions through soft tissues. So it is happening like a tunnel. Like a tunnel, it will create one hole on through the skin. So blood vessels, subcutaneous tissues, soft tissues will getting worst affected. Okay, affected worstly through the tunnel, like a tunnel area, it got affected. So you have to check with the sterile stick or clean stick. You can see the tunnel, how long it is going, like that you can see. Okay, so this is the worst case in pressure ulcers. Then next slide, please. Okay, in stage 4, you can see the muscles, bone, tendon, then the area will got, you can see the gangrene formation, bone, you can see the bone directly, bone tendon also you can see directly. Okay. So you have, before giving to the treatment, before giving to the care, you have to know how to differentiate the pressure ulcer. Then only we can give the proper treatment, proper care to the patient. Next slide, please. So you can see here, pressure sore is unstageable. If it has slough or a scar on top, you can see the black thing on the wound. So there is no blood supply, full dead cells are present there. So it is a unstageable, we describe as unstageable wound. It is like a gangrene formation. So it is more dangerous to the patient. It will spread to the near to the parts. So we have to remove and we have to give the proper care immediately in this condition. Next slide. Okay. First, you are entering into the home visit or patient visit in hospital. So first, you have to do the history collection first. That is assessment. Assessment is more important to give a proper care to the patients. Okay. First, you have to do the history collections, assessments, and related what they are medications. You have to know how they are taking medication, which medications they are taking, how they are daily living activities. Then what about the caretaker? These things you have to know first. In first assessment, in pressure ulcer, you have to know the patient condition. Okay, for example, if patient is having a stroke, so you have to know how long he is in bed, how long, how much level activity he can do, how much level consciousness he is having. Okay, so such assessments you have to do first. Then you have to assess the pressure points. Previous slides, we have seen side lying positions, pressure points, prone position pressure points, and lying position pressure points, no? Bony prominence area. So these bony prominence area, you have to check first whether they are having pressure ulcer or not, whether they are having symptoms or not. As a nurse, you have to check first. Okay, then assess pain associated with wound. If they are having some wound, you have to ask the patient how it came. They will tell many stories, but we can get proper indication for the wound through the patient side verbal words. Then we have to ask the caretaker. Then they have to ask the open question to the patient about the pain. You can use the numeric pain scale also for using pain assessment. Okay, then assess location. Then measure width, length, and depth. In stage 3 wound, we have seen tunneling conditions, no? So that time you have to measure width, length, and depth of the wound to know the stages of the wound. Then presence of exudate. If any exudate is coming from the wound, or any gangrene formation, or any maggots may be present or not. So those exudate forms, you have to know that. Then assess for tunneling with the help of one stick, sterile stick, or a normal clean stick. You have to assess the tunneling. Then you have to record the findings. Okay, that is very most important. You have to record the findings and you have to report to the doctor who is responsible for the patient. Okay, so these are comes under the assessment. Till now we have seen what is pressure ulcer, what are all the risk factors, and what are all the pressure points may get affected with pressure ulcer, then stages of pressure ulcer wounds. Okay, now we have seen assessment. Then next slide, please. Okay, here you have to clearly note down the management. Okay, always medicate patient for pain before wound care. Before taking the notes, you have to separate your notes as stage 1, stage 2, like you have to put stages, and other column you have to put treatment. Okay, in management, then only it will be easy for you. Okay, in management, you have to always medicate patient for pain before wound care. Some people, I have to finish this patient. I have to finish this care now. So whether patient is taking medication or not, anything, we don't care about that. Just like that, we have started our wound care. Patient is shouting like in pain. Then we are disappointed with our care. So before you are going to start your wound care, you have to ask whether patient is comfortable, whether patient is taking all medications. If they are not taking medication, means you have to medicate them first. Okay, then you have to wait for some few minutes, then you have to start your dressing. Okay, in stage 2, it is a simple on non-blanchable erythema. So in stage 1, you have to teach caregivers to turn and excellent incontinence control. You have to teach first, you have to teach the caretaker to, you have to change the positions often. Then you have to do the excellent incontinence control. You have to use the proper panties, proper cloths, wet protection cloths, wet protection sheets. You have to maintain like that. You have to give education or awareness to the patient caretaker. As a treatment process, here we are using liquid paraffin on the particular affected area. None other medications we are not using. Here we are only using liquid paraffin or petroleum jelly on the stage 1 wound affected area. Okay, none other treatments. Then stage 2. In stage 2, you have to clean and you have to dressing with the normal saline. Here also we don't use any medications. Okay, just cleaning with the normal saline. Then we are giving dressing to the patient with the normal saline only. Then again, we are giving education to the caretakers. Okay. In stage 3, stage 4, and unstageable conditions, that slough pressure means we seen the black one thing, then some white discharges on the wound, no? So that should be done by a surgical debridement. So through the surgical debridement, we have to remove the slough or other exudate product in a very sterile method. Okay. Then use normal saline for wound cleaning. You have to advise the patient to surgical debridement anyhow. Then after that, you have to do the normal saline. You have to use the normal saline for wound cleaning. Okay. In home care setting, we can advise the patient to do the home home care saline, homemade saline. Okay, I'll teach you how we have to make homemade saline. Okay, then next, if there is an odor or infection, you have to add metronidazole powder to a gel lubricant, white petroleum jelly, and spread on the wound. Just you have to take the metronidazole pill and you have to crush that. Then you can mix with the gel lubricant, white petroleum jelly. You can mix. Then you have to apply on the wound. Okay. So wound, and you have to leave for some time. So as the caretaker to repeat the same for twice or one in a day. You have to advise the patient according to the patient conditions. Okay. So these are the management for 4 and unstageable wounds. First, stage 1, just apply liquid petroleum jelly and advise the caretaker to change the positions, and wet-free environment they have to provide to the patient. Then stage 2, cleaning and dressing with the normal saline is enough. Stage 3 and stage 4, unstageable. If slough is present, surgical debridement, you can use normal saline for wound healing. If exudate present means we can go with the antimicrobial creams, the tea bag creams we can apply with the doctor's advice on the pressure wound ulcers. If there is an odor or infection, you have to add metronidazole powder with the gel lubricant, then you can apply on the patient wound. So these are the management, simple management. You can do the home care itself. Homemade saline we can use in cleaning purpose, for dressing purpose too. The next slide, please. Okay. If you are going into the patient house or patient room, means we can smell the odor, bad odor, because of that bad infection, bad bacteria. So the simple management is put the charcoal under the bed, will absorb odors. Okay, so charcoal, we just collect the charcoal and spread on the under the bed on the dry cloth. It will absorb all bad odors quickly. Then some people use hypochlorite solution, some like povidone iodine, hydrogen peroxide on the wound to stop the exudate. That is a wrong thing. You should avoid hydrochloride solutions, povidone iodine, then hydrogen peroxide on the wound directly. Then you have to go for surgery consultation. So next picture is, this picture is negative pressure dressing. So I'll teach you next slide. Next slide, please. First slide, previous slide. Okay, homemade negative pressure wound therapy. Here it is working like a vacuum cleaner. So you just apply on the sheet which is present, which is coming with that vacuum, like wounding dressing vacuum. You just apply like third picture. Then you have to set the pressure on that. In minimal pressure will be needed. So that pressure will go to the wound, that will remove the excess exudates, and it will promote the wound healing by the negative pressure apply. It is very rare phenomena. We are mostly here in Tamil Nadu, we are not using this. Next slide. Then okay. For home care patients, many people can't able to buy the saline because of cost. So cost is less, but they have to get continuously. So we can address them to do homemade saline and dressing supplies. So normal saline we can made in house. We have to take 500 ml of water and add 1 teaspoon of salt. We have to boil it and cool and keep covered until it needed. Okay. That wounds are not sterile. So that saline has to be clean and not sterile. It is not a sterile method. It is a clean method. So we can use the clean normal saline water boiled with the salt. So we can use for the dressing purpose and cleaning purpose of the stage 3, stage 2, and stage 4 wounds. Okay. Then for gauze piece, we can take the old dhotis, like cotton dhotis, cotton saris. We have to, that should not be color free. Okay. So we have to cut them into squares. We have to put it in a cooker. So for half an hour to 1 hour. So we have to steam that. Okay. Anyhow, we have to steam that. It will be a clean and sterile one, like a CSD method we are using in hospitals. No, like we have to steam them half an hour to 1 hour. Maybe impregnate them with Vaseline or liquid paraffin. We can impregnate that. Then we have to apply for that. We can use that for the applying ointments, applying normal saline, and applying for dressings. So these are all the homemade saline and dressing supplies. Next slide, please. Okay. Okay. Till now we have seen how it is coming stages and how we are going to treat that. So prevention is always better than cure. So if we are expecting patient is going to have pressure ulcer, anyhow the patient condition, patient situations. So we can advise them for some preventive methods like position change. They have to do this must every 2 to 3 hours. For a bedbound patients have to change their position. Every 15 to 20 minutes for a chair-bound patients. If they are sitting long time for wheelchair, they have to change 15 to 20 minutes their position. Okay. Every 2 to 3 hours for a bedbound patients have to change their position. Okay. Then with the help of some liquid paraffin or white petroleum jelly, we can give the massage to the patient's bony prominence area. Okay. If patient is not having much wound or pressure ulcer, but they are prone to have pressure ulcer, they are under the risk factors, means we can just give massages on the bony prominence area. So you have to advise and you have to make aware to the patient's caretaker. Okay. Then manage incontinence. Proper bed-free environment we should give to the patient. Okay. For the bedbound patient is necessary. So you have to teach the bed-free area, wrinkle-free sheets. Okay. Then special surfaces, air mattress, water mattress, pillows, and cushions. So such a comfortable devices we can provide to the patients. In air mattresses, in water mattresses there is no complaints. In air mattresses, we before 2 weeks we received one complaint. In air mattresses, because of the heat, because they are using raw mat without any bed sheets like that, they have developed some blisters. Okay. So we should advise the patients before using the mattresses, you have to put some cotton cloths on the air mattresses like that. We have to advise. In raw mattress, we should not use. Then pillows and cushions, that should be wrinkle free. That should be very soft. Some patients, some caretakers, they are giving a rough cloths, rough surfaces to the patients. So we should ask them to avoid those things. Okay. Then nutrition, hydration, and some little roam exercises, range of motion exercises. We know, no, abduction, adduction, flexion, extension, rotation. So minimal exercises we have to teach to the patients. Then proper nutrition, protein diet, and hydration, full prevent from dehydration, fluids diet. So So type of diets we have to give to the patients to maintain nutrition and hydration. Some small exercises we can teach them. Then before I have told you, massages with the help of liquid paraffin, white petroleum jelly, we can give to them. Then wrinkle-free bed. Then final one is nail care. Yes. Patient is patient is on prolonged time bed. No. So patient is having some itchings due to the poor blood circulations or any other causes. Patient is having some itching tendency. So patient will start to scratch like that. Till that blood vessels collapse, they will start to scratch. So the caretaker or the home nurse or the nurse have to give the nail care at least weekly once to the patients. Okay, shorten the nails are more important to the patients. Okay, next slide, please. Okay, these prevention, SSKIN. This is a mnemonic of our pressure ulcer prevention. Okay, first one is supporting surface. Make sure your patients get pressure relief on proper supporting surface. Okay, you have to make sure patient's surface area should be pressure free. Okay, that should be soft and wet free. Then second is for skin inspection. Regular skin inspection requires overall body prominence at risk areas. Caregivers must be able to pick up the earlier signs. So if the patient is prone to having pressure ulcer or many incidents are there, if the patient is going to have this pressure ulcer, so like prevention is better than cure. So first you have to teach the caretaker to see the all area and inspection over the area, and earlier signs have to be picked by a caretaker. So you have to teach that. Then K for keep moving. Proper positioning and frequent posture changes are required there. Then incontinence and moisture control. Bladder and bowel care. Catheterized bladder if needed. Frequent change of dressing and diaper. So diaper should be changed in frequent intervals. And if patient is having catheter, means catheter care should be maintained. Then in a frequent interval, catheter should be changed. That catheter care will be given every day. You have to assure that. Then nutrition and hydration. Patient must have right diet and fluid intake. So patient should take, they are in bed now. Why we have to give this much level of food? They don't digest. Like that, caretaker will think, or any other person will give advice to them. But we have to make a diet chart for the bedridden patient. As a home nurse, as a nurse, we have to give the proper diet to the patient and proper hydration to the patient. Okay. Next slide, please. Okay. Then you have to engage patients and family. Here in palliative care, we are concentrating not only patients, we are concentrating on patients, family members, caretakers too. We are addressing them pressures, them depressions, them discomforts too. So first you have to involve the patients and families in pressure ulcer prevention. You have to tell the importance of preventing the pressure ulcer, then consequences which is caused by a pressure ulcer. Okay, so develop a contract of care. What can we do together to prevent pressure ulcer? We just leave the caretaker. You have to take care. You have to maintain a wet-free environment. Like that, we should not say. We have to do. So we have to change like that. We will teach you. We will beside you. We will behind you. Like that, you have to say. We have to make the confidence on the patient family itself. Okay, then only they will believe us. They will give the proper response to our advices and education. Okay, then only the patient will get the bedbound patient will get the proper care. So engagement of family involving them is very important. Okay, so patient information leaflets also have to kept with the patient's caretaker. So in case the caretaker is more aware, more educated, means we you just ask them to maintain the leaflet of the patient conditions. Okay, this is the teeny tips to maintain a high profile care to the patients. Okay, next slide, please. Okay, fungating wound and cancer wound I'll teach in the next class. Okay, thank you. If you are having any doubts, you can ask. This is a time for asking doubts. For any clarification, you can ask me. Half an hour more, so you can 25 minutes more. You just ask me. Any doubts?
Dear participant, if you have any doubts, please unmute your mic. You can ask ma'am. He is here to clear your doubts. And
Excuse me, ma'am.
Yeah, tell.
Yes, ma'am. For management of stage third and fourth or unstageable pressure sore, we have to use metronidazole powder. So we
Yes.
have to mix. We can mix with lignocaine jelly also for
Uh,
applying.
so for if patient is having more burning sensation, means we can go with the lignocaine jelly, but it is not preferable always. You can go with the petroleum jelly. So patient is having more burning sensation, means you can go with that.
Okay. Okay, ma'am. Thank you.
Any other questions, please?
Ma'am, which technique is applied for cleaning wound ulcer? I think from central to peripheral or peripheral to central.
Sorry.
Ma'am, which method used for cleaning for decubitus ulcer? I think from center to periphery or periphery to center.
Always you have to use peripheral area to central area. You in that case you have to use 2 gauzes. Okay, for more infectious patient, so you have to use the more 2 gauzes. It is helpful here. For
Okay,
one
ma'am.
stroke peripheral area, you have to use one gauze, and other for central stroke, you have to use other gauze. It will help.
Okay, ma'am. Thank you.
Any other doubts? In dressing, we should not give more pressure on cleaning purpose. Okay. For gentle way, you have to give the strokes to clean on the wound, pressure wound, because already blood vessels got damaged due to the pressures. So if you are giving forcible pressures on the wound, means that blood vessels got deeply injured. So any other doubts?
thank you, ma'am. We have learned many new things in this class. Overall, it was very interesting lecture.
Thank you.
And anyone? Sagar, Jyoti, Neetu, Shanti. Is everything
No,
clear?
no, ma'am. Yes, ma'am. All clear.
So thank you,
In
Revati ma'am. It's a wonderful session.
thank you, thank you. But sorry, I'm sorry for the inconvenience
Yeah, that's
because
okay,
here
ma'am.
2
Every time
days
we
we
have
are
some
facing some
technical
network
issues.
issues. Yes.
Yes, yes.
Thank you for the support, Arya. Thank you so much.
This is Hannah.
Oh, Hannah, sorry. Thank you,
okay.
Hannah.
Okay,
Thank you so much. So, any doubts you can ask. Again, I'm asking.
Unmute.
Sorry, ma'am.
Any doubt you can ask.
So participants are saying thank you. So
So, it's a time for leaving. Okay, thank you. We will see in the next class. Thank you so much.
Sure.
Thank you.
So participant, we have postponed the class to Monday, 11th August because of this Rakhi festival. Thank you. You can leave now.
You don't have.